Good afternoon, everyone. Can you hear me? Can you unmute? Okay. So today we will be discussing a stepwise scientific approach to diagnosis of a very rare condition, especially in the critical care settings. I'm sure that not many would have seen cases of Porphyria. Nevertheless, these are the cases that get missed. If you keep your differential diagnosis broad, probably and take a stepwise approach to everything, then I'm sure that you will not miss these conditions as well, because these are conditions that exist. And the patient really suffers if these conditions are not picked up in time. It's not only here in India, but even in the US, quite a few, US and Europe, I mean, we have quite a few studies and quite a few cases that have been reported, which reflect the amount and the degree of suffering the patients had to undergo. So looking at just one second, I'll change the slide. Okay, so this is what we're going to discuss today. A little bit of a history, the myth, the legends, the madness, living disease overview, and then you have an introduction to one of the drugs for the treatment of Porphyria. Now, this has been there for a very long time and through history. Now, it's been through myths and other things as well, legends, myths, and what the reality was. There is an array or a spectrum of many signs, symptoms, psychosis, neurosis, and other things that have actually got mixed up with the legendary vampirism or the story of kings and queens. Now, patients were presenting with protruding teeth, sensitivity to sunlight, so they loved to live in the dark, craving for blood, disfigurement, and these are the werewolves and vampires of the Middle Ages that were actually suffering from. These were scientists suffering from Porphyria. Looking at the royalty, madness of King George, that is 1765. King George developed intermittent depression and agitation, and his health worsened. Urine was described as bluish red color. Now, as you know, that in Porphyria, you have a typical red colored urine that you see. The symptoms are they're thought to have been caused by Porphyria, and especially eyesight, suffering from dementia, and then he died blind. Then Queen Victoria, as a daughter and a granddaughter, they also had Porphyria. In 60s, the bodies were exhumed and tests were revealed that they had an intrinsic mutation in the protoporphyrin oxidase gene that suggested variegate Porphyria. Now, disease over. What is it? Why are we discussing Porphyria so much? And what is the implication? What are the implications of having Porphyria? Now, this is basically a group of inherited metabolic disorders that is caused by partial deficiency of one of the enzymes in the heme biosynthetic pathway. Now, heme biosynthetic pathway, we will go into the details of it. Now, deficit of heme, which is necessary for the synthesis of various hemoproteins. This is what actually happens. Accumulation of heme precursors that are directly or indirectly toxic. So the final word is heme biosynthesis pathway and various enzymes associated with it, whether it is an alteration, mutation, or deletion. This is the heme biosynthetic pathway that results in conditions of porphyria. 7 forms to remember: acute and non-acute. Now, in non-acute symptoms, it's more insidious. Cutaneous symptoms are there, whereas in acute, they're more, the symptoms are neurovisceral, constitutional, and it can be with or without cutaneous symptoms. Non-acute are purely kind of cutaneous. We'll go into the details. Yeah, here is an enzyme. There's an 8th form also. So 7 forms, 4 acute, 3 non-acute, and the 8th form is described as, it's caused by the deletion of an isoform of the 5-amino-livalonate synthase gene, that is, we'll call it as ALAS2. Looking at all of this, this is quite a busy looking slide, but I'll make you very simple. The way to understand a complex situation like this is, okay, you break it up. Break it up into 4 parts. What is it? What does it do? How does it do? And what impact does it have? Now, the rate of heme synthesis is primarily controlled by ALAS, the first enzyme, right? Second, the activity of ALAS in the liver is regulated by the intracellular heme pool by a negative feedback mechanism, right? The enzymes associated are given around here. Third, this regulates the production of ALAS and porphyrobilinogen, which is then converted to heme through a series of heme precursors. And what happens then, that in patients with porphyria, the conversion of ALA, PBG, and porphyrins to heme is compromised by their enzyme deficiency. So look at the steps, look at what the enzyme is. That particular kind of enzyme deficiency will cause that particular disease. And therefore, you have things that are in blue. That is, so on the right-hand side, this is the cytosol. On the left-hand side, it's the mitochondria. On the right side, in the blue, is acute intermittent porphyria and the ALA dehydrase porphyria and coproporphyria. The yellow ones are cutanea tarda, that is porphyria cutanea tarda, and dominant protoporphyria. Okay. Now, looking at acute and non-acute, these are types. On the left, deficiency of the enzyme. Look at what type it is. The type is hepatic. Most of them are hepatic. The rest of the 3 are erythropoietic. So the liver gets involved and erythropoietic. Erythropoiesis also. So what happens is the primary site of excess of porphyrins or precursor, skin lesions, neurovisceral symptoms may occur alone or together, fragile skin, blisters, acute photosensitivity without fragile skin or blisters. Now, if you look at what the disease spectrum is like, starting from abdominal pain, tachycardia, urine, nausea, vomiting, mental changes. Very important are the neurological symptoms that can occur. You can have features like GBS, Guillain-Barré syndrome. You can have sensory neuropathy, Guillain-Barré types paralysis, postural hypotension, you can have convulsions, and even patients can present with coma. Look at the risk factors. Most common people age, they are young. Majority greater than 80% occur in females, 18 to 45. Now, most of the attacks are precipitated by events that are directly related to the ALAS or demand of heme synthesis in the liver. Alcohol misuse, fasting, infection, hormonal fluctuations during menstruation and pregnancy. Diagnosis of porphyria is awareness. It's a key. The fact that this is quite rare. Incorrect diagnosis often leads to inadequate, inappropriate treatment. This we'll see what happens in the next few slides. Inadequate patient management, even surgery. These outcomes can aggravate the attack, and possibly this can lead to further serious neurological complications. Seizures, convulsions, if not controlled appropriately, can actually result in permanent brain damage. So, basic investigation: take a thorough medical history, urine test, that is acute intermittent, variegate, and Porphyria are associated with increased urinary excretion of porphyria bilirubin and ALA. And therefore, you can see that the darkening of the urine is a strong indicator. After that, so you've taken the history, you've done the urinary test, then analysis with the enzyme, and then go ahead for genetic analysis. Then the availability of DNA tests may facilitate genetic counseling of the affected families. Now, let's go into the stories of quite a few patients. Now, making the right diagnosis. Diagnosing is very difficult. Often patients see more than one specialist, and then their opinion does have a cross influence on other clinicians as well. Finding out what was wrong with me was the biggest challenge. Once I was diagnosed, I started having treatment and I was able to take control of my life again. This is the statement of one of the patients. Now, it's life-threatening, it's unpredictable, often misdiagnosed, and the fact that porphyrias are rare means they are often overlooked in the differential diagnosis. Incorrect diagnosis also often leads to inadequate or inappropriate treatment that can aggravate the attack. Now, living with porphyria are stories taken from real life, looking at stabbing pain. Now, this is Lucy's story. She's 46. Stabbing pain, fever, rapid heart rate, numb hands and feet. Now, for 23 years, this lady suffered with intermittent attacks of abdominal pain, fever that often lasted for weeks. Look at what she had. She had her ovaries removed, appendix removed, most of the colon out, 13 surgeries. While the doctor was still trying to find out what was wrong with me, and it was really a nightmare. So, look at Lucy's journey. She felt like a knife was being stuck in my gut. First attack at 23 years of age. Pain in the left side of the stomach, increased temperature, delirious, uncomfortable vomitings, chronic constipation, and joint pain. The blood pressure rose to a level that was quite concerning to the doctors, and one of the doctors told me it was all in my head. Well, there are some constitution symptoms and there are some psychological and psychiatric symptoms as well, because it affects the brain. And therefore, you can see one test after another, countless misdiagnoses, lupus, multiple sclerosis. So, well, what happened that after such a long suffering, It's not uncommon for people with porphyria to be misdiagnosed and to undergo a number of unnecessary tests and surgeries before they're correctly diagnosed. And then somebody said, has anyone ever suggested porphyria to you? I felt like I'd finally found my answer. All the strange symptoms that I had surgery for being considered crazy could now be explained. 3 months later, she was diagnosed with AIP. Now, for the trainees, acute intermittent AIP is also known as Swedish porphyria. Okay, because in that side, the Scandinavian countries, very fair skin, light blue eyes. Those are the typical people who can get. And I'm also told that there are some areas of Rajasthan here that have incidents of porphyria also. Another story, Mary, 67, blistering skin, abdominal pain, urinary retention, psychiatric problems, multiple hospitalization, unnecessary surgeries, depression. She even attempted suicide and was admitted to a psychiatric hospital for suspected paranoid schizophrenia. So the doctors had no idea as to what was happening and was causing depression. Her symptoms worsened when she reached puberty, including intermittent attacks of severe abdominal pain, depression, which persisted throughout life. After 55 years, my prayers were answered and so relieved that finally we have a diagnosis. Well, I just wish it could have come sooner. A friend's husband, retired physician, heard about her symptoms and suggested porphyria. 2 months later, simple urinary tests confirmed that Mary had a variegate porphyria. This retired physician has only ever seen one other case in his entire career. So the life could have been so very different if someone could have been picked it up early. How do we manage it? Okay, now, once you've diagnosed, so diagnosis is go through the history, get a urinary test, then get the enzymatic tests, and if you have genetic analysis and facilities for that, then go ahead with that. Managing porphyria, managing means prevention and treatment, preventing acute attack and treating acute attacks. Dose and dosology, pharmacology, and mechanism of action. Now, looking at preventing these attacks. We have time? Yeah. So, about these factors, there are comprehensive lists available that how do you, what is the prevention part? So you avoid the factors that increase the risk of acute attack, wear a bracelet, inform any doctor, surgeon, dentist, or anyone before any treatment that you might you have that there is a background of porphyria. Okay, looking at what the treatment part is now. Any drug that provokes the must be withdrawn. Supportive treatment started. Glucose infusion to reverse hypoglycemia. The ALA and PBG should be started because these are the enzymes that are really compromised. Evidence suggests that hemin is clinically more effective than glucose. Okay, so there is this brand name of hemin preparation. Hemin preparation is one of the vials that is available nowadays with a trade name. And now what this human heman does is what we'll be discussing in the later few slides. The preparation comes in at 25 milligram per mil, and you have to have so this vial contains 250. So that is, it's a 10 mil per ampule, and the solubilize and stabilize this is a complex with arginine suspended in a mixture of ethanol and a propylene glycol. These are the stabilizers. Each ampule is prepared by injection by adding a contents to 100 mils of normal saline in a glass syringe. Unopened ampules have a shelf life of about 2 years when stored at 2 to 8 degrees. Preparation should be used within 1 hour of dilution. Treatment. What are the indications of human heman? That hepatic porphyria, acute, intermittent, variegate, and coproporphyria. Now, a recommendation: daily dose 3 milligrams per kilo once daily for 4 days. So 4 days you use 3 mils per kilo, and this should not exceed 250 milligram per day. And treatment must be repeated in strict biochemical surveillance if there is an inadequate response after the first course. A daily dose not more than 3 for 4 days to be used in children. Now look at the activity, the mechanism of action. That is heme arginate, that's human heme preparation, rapidly dosage in blood. So what happens that it breaks down to arginate and heme to heme hemopexin complex that enters the liver, the hepatocytes, heme pool, the hepatic heme pool that increases, and the quantities of heme incorporated cysts and the ALAS, ALA, and porphyrobilinogen, they decrease. That results in improvement or resolution of clinical symptoms. That's how it is. So it's a, well, this is again the product information that one ampule would contain 250 milligrams, and then 100 that we've already discussed. It's a light proof bag. What is the data for treatment of heman? Efficacy data is mainly arise from small uncontrolled published studies, and here they had 130 patients with acute intermittent, 4 with HCP, and 24 for variegate. And some studies have been conducted in US but are not well included. Looking at heman versus placebo versus hematin versus addition of tin protoporphyrin. And these are the number of patients of 12, 5, and 9. There were 6, and you always look at the ALA and PBG levels and a resolution of constitutional and clinical symptoms. And they all found that, well, alone or in combination with protoporphyrin reduces the ALA and PBG levels. Now, there is, as I said, there's a Swedish study, African study, French study, and a Polish study look at diagnosing and acute treatment open label studies. So they all monitored the ALA and PBG levels, and in all of them, without any disparity, these levels did come down. In the placebo background, again, 9 patients were readmitted with further attacks and were given alternative treatment. Okay. Well, this reduced biological response with hemin was that urinary ALA and PBG levels were seen, all patients treated with Normosang, and 9 patients received both the treatment. This reduced duration of hospitalization and a requirement of analgesics. So it effectively reduces porphyrin precursor overproduction during the porphyric attack. This has favorable outcome on resolution of clinical symptoms. Then efficacy for 4 days treatment, well, hemin versus hematin. Now, this is again 5 patients with AIP received rapid and complete resolution of clinical symptoms, decreased ALA and PBG levels. This was better tolerated than hematin. So hemin is better tolerated than hematin. With tin protoporphyrin, both studies, they showed that ALA and PBG levels were unchanged. This hemin alone or in combination with protoporphyrin markedly reduced the ALA and PBG levels, and the combination prolonged biochemical remission was seen. Early treatment with hemarginate, again the same thing. Conclusion is hemarginate was a favorable effect in patients with acute porphyria. Heme therapy should be started immediately on admission. Now, once we look at the treatment results of this Polish study, that it's well tolerated, prompt initiation improves clinical outcome, improves or resolved clinical symptoms, that is painful abdominal attack in a majority as large as greater than 90%, and a rapid reduction of heme precursors, that is ALA and PBG. Therefore, it is a highly effective treatment of acute attacks of intermittent porphyria. Most important thing, which quite a few people will ask, successful use of Normosang for the treatment of porphyria during pregnancy. Now, what did we see? Time of diagnosis, symptoms of pregnancy, and they symptoms at diagnosis and treatment, and delivery time and weight of the baby and health problems. That's all what was seen. I won't really go into the details of this table, but the symptoms during pregnancy are leg pains, abdominal pain, mostly hyperemesis, and rash. So amongst these patients, you can see the symptoms, number of live births, no symptoms during pregnancy at 3, previous diagnosis of porphyria, diagnosis during pregnancy 2 out of no symptoms, 15, miscarriages 1, cesarean section 2, general delivery 16. No difference between general population of birth weight or miscarriage rate. Case 1, patient diagnosed with AIP before pregnancy. Age 19, frequent attacks, symptoms followed treatment with hemarginate, 250 milligrams once a month. First pregnancy, 25, resulted in miscarriage 9 weeks. Second, age 26, had severe abdominal pain, hemarginate increased to 250. At 38 weeks of gestation, the patient had another attack and emergency cesarean section was performed. Baby was well at birth, developed normally. Second pregnancy, similar management, heme arginate infusions. No previous symptoms, 8-week gestation. He developed severe nausea, urine tests, high level of PBG. Patient recovered following treatment with heme arginate. Regular episodes of nausea, but not have further porphyric attack. Healthy baby was delivered at 38 weeks by cesarean section. Now, conclusion. Pregnancy is typically uncomplicated in acute porphyria. Problems are more likely if it has not been diagnosed previously, and administration of heme arginate during pregnancy is safe, and continuous use of heme arginate during pregnancy has no detrimental effect on the outcome of pregnancy. Well, that was the end of it. Thank you. Now, if you guys have any questions, then you can unmute it, and I'll be happy to take any questions.